individual that measured cervical range of motion with a goniometer. She was Israeli trained. That doesn't mean good or bad. She just had a different kind of training. All right? So she was a physical therapist. She worked with us at Baptist. Wonderful. One of the best individuals I ever worked with. She was Israeli trained. She would measure cervical motion rotation, and rotation only, using a goniometer. That's not good or bad, but I'm trying to give you an indication of what does it look like. The rest of the places I've been and worked with, cervical range of motion and lumbar range of motion, it's reported as a percentage of 100%, if you will, or on a diagram that looks like this. All right? And basically the diagram works as follows. Let's say I'm looking at the cervical spine. On this axis, the y-axis, I have flexion. F stands for flexion. Extension stands for extension. This is right side bending, RSB. This is left side bending, LSB. This is right rotation, and this here is left rotation. All right? That's how I label my diagram. You may go somewhere where they label it a little bit different. As long as you know what these axes stand for, in other words, how they're labeled, then the method of how to use it is very simple. I.e., if I ask my patients to flex their neck, their cervical spine, and they show, I see it, as about 50% of the range of motion, I would draw a line here. Okay? It's about 50%. It's not perfect. As I look at it a little bit more careful, maybe it's right here. Okay? And it's not meant to be a scientific tool, i.e., I would not put this against a reliability test because I'm sure it's not perfect. It's a way for us to talk and communicate with one another. So some people can communicate very clearly, some people will not communicate as clearly. This is not as clear communication, but nevertheless is communication. Are we good? And clear with that? So, the other thing I've seen, I don't like this. The other thing I've seen is that if at 50%, and let's assume 50% is right there, the individual is limited by pain, so they went to flex their cervical spine, and they were limited. They couldn't go any further because of pain. I've seen clinicians put 2 lines. Okay? So 2 lines would denote that flexion, about 50% of flexion, midway of the motion. The individual could no longer, right, flex because they were limited by pain. Okay? Equally, the individual could be limited in flexion, and let's say they were limited in right rotation. So this is flexion, and this is right rotation. All right? So that same individual I'm examining, I ask them to rotate their neck, their head, their cervical spine, their head to the right, look to the right and look to the left. And let's say that now they're limited about 75% of the way. All right? So they go from here, and they show me about 75% of the range of motion. What I would do is the following. I would put a line somewhere, so if this was divided in 4 pieces, somewhere denoting about 75% of the range of motion. Okay? Right rotation, limited by pain in this case. I said pain. About 75%. About 75%. I keep going back. It is not a scientific tool. It is not a tool that's used for research for the most part. It is used to communicate with one another. It is not perfect communication. Yes?
Then the second line means that it's limited by pain.
I've seen it used like that. Okay? I've also seen individuals write a circle. Okay? A circle denoting the same thing. Whatever it is, wherever you're at, okay? The system is really about a line, a circle, a double line, an X, and all of these things should be, and often are, defined in the clinic for you, where you may be and where you would be communicating with other folks. You hear me? So I don't want you to write 2 lines equals pain 100% of the time. That is one example of one of the ways it's used. A circle can denote as well. Okay? Are you with me on that? One way to report. What are other ways to report? Another way to report is just to write down flexion, extension, let's say right rotation, left rotation, and write it right here, limited 50%. So I would put limited, I don't know, 75%, whatever it is, whatever language you guys are utilizing in the clinic where you're at. Okay? What you're getting from what I'm saying is range of motion, cervical spine, lumbar spine, often, the majority of the time, reported in terms of percentages and not in terms of the range of motion that we have been doing up until now. Are we clear? Any questions? All right, so, Lynette, come up here. The other thing I want you guys to know and experience with one another for a few minutes. So, Lynette, you're looking that way. Lynette, can you do me a little favor? Can you put your hair like in a bun kind of thing that you guys, that's what I would tell my patient.
I have a scissor here.
Huh?
Another
Okay,
difficult patient.
That'll work. So listen, we're first gonna do it her facing that way. And I always ask the patients, can you place your feet shoulder width apart? All right, and parallel with each other. And this is what I want to do. I want to put my hands on her spine, right? Because I want to feel the motion that's taking place. I am now going to be looking at the segmental. So gross motion is this. Gross motion. All right? I am now going to be honing in on segmental motion. And what do I mean by segmental motion? I'm trying to the best of my abilities, I don't have x-ray vision, to the best of my abilities, see how each one of these segments move. What happens? What happens is that if I note limitations that are segmental limitations, right? Then I can choose to utilize my mobilization techniques. I don't know if you guys learned spine mobilization techniques here. I don't really know. It's out on your...
Spine is on
the last week.
Okay, so anyway, I don't really know how that works, but there are mobilization techniques that we can...
You can study spine.
I don't think we learned it yet.
I don't know if it I don't know if it matters right now, other than you guys understand, just like you've been doing mobilization techniques for the shoulder, there are mobilization techniques that are specific to each segment. And then there are mobilization techniques that take segments as collections of vertebrae. Again, this is, stuff that either you'll get later.
Wait, sorry, when you said segments, it's not cervical, thoracic, lumbar, no, or is...
Well, the meaning of the
three
word,
vertebrae.
the way I was trying to explain it to you here was, individual segment. But the word segment in English is, it's not limited by just one segment. So I want to be true to the vocabulary, because there are fields of study, if you will, in our industry, that instead of mobilizing individually, they mobilize by segments, larger segments.
Two,
Or
three
sections.
vertebrals.
Sometimes the entire lumbar spine, sometimes the entire thoracic. Higher level knowledge, that pertains to the treatment of the spine. What I want you guys to grasp from here is, just like range of motion is limited in the shoulder, and we choose to mobilize the shoulder to improve range of motion. I know you guys have had that, right?
Okay, yes.
Well, the same thinking, the same modality, if you will, exists for the spine as well. All right? Are we good with that?
Yes.
That's the thought process. When you get it and how you get it, we'll leave that up to somebody else. All right? So, I place my hands on her spine. I obviously would have explained to her that I want to see how she's moving. I would have had a model of the spine next to me in the treatment room, so I can show her that these segments move individually, right?
Yes.
That's a scenario. And then I would ask her to let me guide her motion, okay? So let me guide your motion, because I want to go really, really slow first. This is what I want you to do. That's how fast I want you to move, okay? And keep going, keep going, keep going, keep going, all the way down,
Look at her.
all the way down.
Amazing.
Yeah, look at C7. Keep going down.
Wow.
Bow, 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 bow. So look what happened, you guys. If you remember from your anatomy, a lot of flexion takes place in the cervical spine. Very little flexion takes place in the thoracic spine. So look what she does. Move slowly, slowly, slowly. Now keep going, keep going. You see what happens?
His lumbar is working right.
Well, she skips. She skips, meaning we're not able to see all that happens here. Part because of our limitations. There is some movement. But it's a lot less movement in relationship to the cervical area. All right? And what you're doing is she has to be able to move slow enough for you to be able to pick this up. And then try to put it together along with some other symptomatology. If she was in my clinic, she would be in a gown, correct? The gown would be open, so I'm looking at the entire movement of her spine as she is moving into forward flexion. We would do that for forward flexion, we would do that for extension, and we would do that for rotation. And then I would be looking to see, depending on where her symptoms are, I would be looking for limitations, segmental limitations that I can address later with mobilization techniques. All right? I want you to practice that with one another at least twice. All right? And the thing to get from here is you want to look at it and you want to give your patient clear enough verbal cues that they're not moving. They're going to have a tendency just to move fast. Because most of us just don't take the time to move that slow. All right? So we're going to guide them with our hands first and our verbal cues. Then we're going to stand away so we can visualize the spine once they've learned the movement, and we're going to look at the movement. Are we good? All right, go do it. You got about 15 minutes to do that.